I'll start. So this is a sort of an extraordinary meeting. We're joined by two people who are going to speak this evening. So the two individuals are going to speak about COVID, and Nabil Jarad is a respiratory physician in Gloucester Royal and has been, more than most of us, has been at the coalface of the illness that we've been living with for the last year. He's going to be joined by Prof Goddard. Paul was a radiologist in the BRI, and they are going to talk to us about drugs and COVID and new presentations. So Nabil, I'm going to you can share your screen. I'm going to turn my camera off, and the floor is yours.
Thank you very much, David. Can you see my screen now?
Yes, we can.
Okay, so as David mentioned, I will be starting to talk about corona and corona vaccine, and Paul hopefully will talk about repurposed drugs for corona, because currently there are no purposed drug for corona. There are no treatment that has been designed to treat this virus. So this is the number of patients as in 6th of February.
So Nabil, sorry, Nabil, you're not actually sharing at the moment. You've unshared.
Oh.
So it was there and then it disappeared.
Can you see it now?
So I can see COVID dashboard.
Yeah.
Okay. Right. You've got control again.
Can you turn it into a slideshow?
Yeah.
Yeah, I'm doing that.
Good man.
Can you guys see it now?
Yes, thank you.
Oh, good. So
Jonathan,
these are the number of, sorry?
No, sorry. I'll just get rid of Jonathan there.
These are the number of patients on the top that has been hospitalized for COVID, and it has reached the peak of the 3rd week of January. This has gone down fairly dramatically. These are the number of daily admission for COVID, and that has gone down dramatically. Vaccination started in the 1st week of December, and I got my vaccine, my first shot of vaccine then. And since then, there are approximately around 200,000 people vaccinated in that neck of the wood. So certainly, in fact, the peak of the COVID has gone down, which is compatible with the national picture. COVID, however, has changed the world, really. It has its own economical impact. 90% of the countries in the world has got shrinkage of their economy, and the risk of hunger around the world has been mounted, and I have direct experience with that, which I will be alluding to. This is really an important slide that is being published fairly recently, and that is the effect of COVID-19 on the world economy. On the y-axis is the number of death rate, and on the x-axis is the shrinkage of economy throughout the world. So this is here shrinkage of 5%, 10%, and so on. The size of the circles represent the actual size of loss of economy. And you would like to be in this particular area, and Southeast Asia and some Eastern European countries are doing and done well through the COVID period. The worst country in the world is Peru, because high death rate and high shrinkage of economy, mainly because of the fact that there is loss of tourism. But look where the United Kingdom and Spain is. Really, in fact, the 2nd worst country in the world. This is the US, which has lost a huge amount of their economy and of their people. So this is really the impact of COVID on the world economy. Paul will talk about therapies, but it is well worthwhile mentioning that COVID is not only a lung disease, it is principally a lung disease. What is different between COVID as a virus and between other viruses in the past is the effect on other organs. COVID specifically affects the blood vessels, causing something called endotheliitis or vasculitis, affecting the lung itself. This and the effect on the lung tissue per se is a maximum factor which causes hypoxia and contribute to the mortality. Also, it does affect the heart. Myocarditis is being reported at least in 30% of people, which would last well after the recovery from COVID. The fourth organ, which people don't particularly pay attention to, is the brain. Subacute encephalitis has been reported in anything between 30 to 50%, and the patient will come and say, I have mental fogginess. The encephalitis that happen is one of the factor that is responsible of loss and taste and smell. I think Tom and Jonathan asked us to talk about post-COVID, and that may well be a subject for another talk. But the fact that COVID affects all these organs and causes damage in each one of them is responsible of the post-COVID syndrome. Most people who are affected with COVID are asymptomatic or have mild disease. Some will have moderate disease with some chest symptoms, but their oxygenation is normal. And this is 85% of patients. Some people have severe disease, go to critical disease when they required assisted ventilation. And then these are the end stage of COVID, where more than one organ is affected, the multi-organ failure. And that affects 15% of the patient, this particularly severe phase of the disease. What will determine who goes from here to here are these risk factors, particularly age, diabetes, high blood pressure, and ethnicity. The burden of the disease is big. Many people say that why all the fuss of a disease that causes 2% of mortality? It is actually causes 15% hospitalization, and the long COVID without lung injury is seen in a third of people, consisting of fatigue, breathlessness, cough, myalgia, depression, mental fogginess. And with our studies, in fact, are looking into that fairly carefully, and that could last for months to up to a year. Lung injury is seen in 15%, causing organizing pneumonia and lung fibrosis. And there are people who have this 2 and 3 together, which is post-COVID and lung injury. So it's actually have a high impact disease. We now have a toolbox, a prevention toolbox, anything from social distancing, cleaning, protecting face, and I will be focusing on the vaccine. COVID has affected the profession in a big way. To deal with the high number of COVID, there are 2 initiatives most of the hospitals are doing. The first is the so-called virtual ward. And this is a patient whom I have seen recently. And this patient has been asked when she came in to the clinic, she was given pulse oximeter to record her pulse and her oxygen saturation, and also some sort of symptoms, whether feeling better, worse, or just about the same. And she would send those, and then we would, this patient, as it happened, didn't have COVID, but she was asked and be treated as someone who has COVID, and that's called remote monitoring COVID diary. Many people have had initiative of the virtual ward in which all people have been given pulse oximeter And the GPs, the patient, and the hospitals have been given some sort of pathways, what to do with mild symptoms without oxygenation, stay at home, moderate symptoms with or without oxygenation, telephone consultation or video consultation, and severe symptoms where they can have a GP visit or come to the hospital. All these are automated and can be checked by GP or by hospital physician. Of course, phone and video consultation has also become taken place. This is has happened for pregnancy, but it is something that is happening in respiratory cases and respiratory clinic as well as in COVID clinic. One of the biggest impact currently of COVID is the virtual disappearance of the outpatient clinic and replacing the outpatient clinic with phone clinic. So this is a normal outpatient clinic in which the patients are waiting. They come to the reception, either by themselves or being brought in. They sit side by side, and they are then invited by the nurse to see either the nurses or the consultant. This is not conducive to prevention of transmission of disease, and the whole thing has now disappeared and replaced by something called phone clinic. And the phone clinic consists of us getting access to the hospital system, including the patient's details, radiology, and their investigations, and some sort of referral. And then we give the patient a phone call and do a consultation on the phone. We prescribe, we do investigations as such. And in fact, the dictation of the letter happens through our mobile phone. And although we all have been skeptic to begin with about this, because it does obviate the face-to-face and the human contact with the patient, it did actually have advantages. We started this in March and continues until now. It has advantages that the patient did not need to travel to clinic. Allocation of clinic space is always a problem. There is no need to do that because the clinic spaces are empty. Our car parks and hospital have empty spaces, and the clinic staff, such as the receptionists and nurses, can be redeployed to an inpatient. So it did make a difference. This is sort of an example. This is a patient who have a nodule follow-up. We have a contact with the patient. We have their blood tests. We have their blood test over a period of time, which we can track from home. And if the patient has been admitted to the hospital, these are their observations that has been electronically being visible. From my point of view, coming from the Middle East, we have the woes of poverty as well as the Middle East problem, but taking advantage of the phone consultation, I have with a few colleagues decided to do a phone consultation to patients in the Middle East. And I have broke a lifelong promise not to join WhatsApp or Facebook by joining both. This is the advert of the clinic, the virtual clinic, which is done on Monday afternoon. And this has been translated later on with English. Of course, you all know what that says, but it is really just an advert for the clinic itself. And the patient would send with them either through WhatsApp or the messenger their investigations. This is CT scan. And this patient has sent picture of their x-rays, picture of the medications they're taking, the blood test, and the lung function tests. And I would give them a phone call and will give them an advice and guidance. And then I will write to them with either messenger or WhatsApp using the Arabic language, which I become acquainted with recently about advice and guidance. Over the past now few months, I had over 300 requests And also there was plenty of follow-up for the patient who have been sought help. Initially, this has been directed to the Middle East, but I have been getting consultation from throughout the world, including part of Europe, Eastern Europe, and the Gulf states. I would like now to focus the next of the talk about variants and vaccine. Just to say one thing, that COVID virus, before it enters the cell, it has to get the spikes to be attached to a receptor called ACE receptor number 2. And this is like a lock and key. And once the receptor has been attached to the spikes, it does open the cell membrane. The virus comes inside the cell and destroy the cell accordingly. And in fact, this is just a representation of the fact that the ACE2 inhibitor, this is the lock of the house, our house, and the key have to be compatible. So the viral spikes and the cell membrane, the ACE2 inhibitor has to be compatible. However, with a period of time, these do change. And sometimes the virus has to go into other locks in the house to enter the house from it. These are the viral antibodies when they come in, and the viral antibody has to match the spikes itself. And sometimes when the spikes change a little bit, the antibodies still work. And the antibodies, when they are attached to the spikes, it stops the virus of entering the house. However, it will not be recognizing the spikes if the change of the virus has been quite large. And currently there are several spikes, several variants. The Kent variant, which is a little different from the original one. The Brazilian variant, a bit different, but this is in fact the big one, the South African variant, which is really quite different from the original COVID virus. There are other one, which is the Bristol one, which are very few people, and the Liverpool one, which are there. So the vaccine, which has been designed for the original virus, have some sort of efficacy on the majority of those, but has probably less efficacy in the South African variant. I can say that the most recent research has shown that the vaccine available to the original virus affects the severe part of the disease of all of these particular variants. Now, they talked about being rapidly transmissible variants, and the reason for the rapidly transmissible was initially unclear. And in fact, Prof Goddard, with discussion we had a few months ago, says, could you ask your patient whether they sneeze more? And indeed, I have been asking the patient in the second wave and the third wave, and they do have more nasal symptoms. And that indicates that the virus is stuck to the nose before it goes to the body, and there are high content of the virus in the droplets. And this is why it is rapidly transmissible. There is more of it, and it is stuck in the nose, and nasal symptoms are more common in the second wave than in the first wave. The vaccine currently's job is to stop people going from this particular mild phase to the severe phase. So it does affect the asymptomatic of becoming symptomatic, or those with mild symptoms of becoming severe disease. So the aim with the current vaccines is to stop COVID of being a lethal disease and make it just being a disease which is like a flu. And people say that the vaccine's productivity has been rushed, and this is one of the problems with the vaccine. However, COVID is not a new disease. COVID has been with us in 2003 by a condition called SARS. And then in 2012, it has reappeared again as of the MERS, Middle Eastern Respiratory Disease. And then, in fact, in 2020 and 2019, appeared as a COVID. But if you look to the virus, it really have very similar proportion or similar architecture. It is a spike, RNA, and lipid for SARS. Spikes, RNA, and lipid. Spikes, RNA, and lipid. And in fact, when this has emerged, there have been plenty of attempts to produce vaccines, but as it happened, they disappeared without the need of the vaccine. So, and when COVID-19 appeared, the blueprints for the vaccine were present. So the vaccine has not been rushed. It has been there for a few years. But also there's something else which has occurred, which is really quite important to note. This is the way the vaccine has been produced, and this is the way that the vaccine regulatory has been also approved. So this is the vaccine for the dengue. And if you look to the animal trial, it took 2 years. Then the submission for doing the phase 1-2 trial, it took again a year or so. And then phase 1 take 2 years, phase 2, 2 years, then 2 to 3 years. The regulatory authorities took 2 years, and then the productivity happened after that. So it took 15 years to produce vaccine for the dengue virus. Contrasting with that, you can see that this period has been gone into months. And in fact, the regulatory authorities took weeks to submit, to accept phase 1, phase 2, and phase 3 to happen. But if you look carefully, that phase 2 started after the interim analysis of phase 1, and phase 3 started together with the production of the vaccine, and whilst the interim analysis happened to phase 2. And that took months, with the submission to the regulatory authorities took weeks. So, and the funding has been available in abundance because of the political support to the production to the virus. So comparing to 15 years to produce a vaccine to the dengue, it took nearly 10 months to 1.5 years to produce any vaccine of COVID. And this is why we see the vaccine happening within a quick period of time. And these are the initial vaccines, the Pfizer-BioNTech RNA vaccine, good efficacy, need ultra cold temperature, 2 doses recommended with 3 weeks apart. And I will talk a little bit about 2 doses and 1 dose. And it costs about £30 with the 2 doses. AstraZeneca, it is different. It is a viral vector, good efficacy, storage 2 to 8 degrees, 2 doses 3 weeks apart. And it's actually the amount of produce now is not for profit. So it costs nearly, in fact, £3 for it. Moderna is similar to BioNTech, costs £20 to £30, 2 doses. Sputnik, which is the Russian vaccine, is also have good productivity and doesn't need ultra cold temperature. And the price is £7 for every dose, but given to many people now free for charge. There are 3 vaccines come from China, and this is the Sinovac. The difference between Sinovac and other vaccines that it actually have the whole virus being attenuated, has 2 doses with the optimal dose available, stored in room temperature, and probably costs £5. And this is the new boy on the block, which is really quite an important new arrival. This is the Johnson & Johnson, the Novavax, uses viral spikes. The efficacy is 60% to all types of presentation of COVID and 100% prevention of ITU and mortality. It costs £7, but the main advantage is 1 dose. Not only is the convenience and the efficacy of 1 dose, but reducing the logistics of getting people back to have their second dose. I like this picture because this is a family in Turkey quite a few years ago. And this guy with the yellow shirt and who has no shoes was the same man who, his name is Oga Sahin. And Oga Sahin went to Germany, became a biochemist, and later on went to the US. And he and his wife did the BioNTech part of the Pfizer-BioNTech, and he is the one who produced the first and perhaps the most potent vaccine available till now. So there's in fact plenty of hope for our children, hopefully. So these are in fact in the vaccines. I put the slides here to make 2 points. The first is that we know that the Pfizer and Moderna use RNA, the rest use vector and or attenuated vaccine. There are now a clinical trial to mix and match these vaccines, i.e. to give the RNA and the vector in a randomized way to see whether this is very effective, which is really quite a good news. The second thing is to actually look into the purchase of these vaccines. So for example, the EU procured 400 million doses, the US 300 million doses, and so on. And if you look to the vaccines, you see that the procurement has been mainly in countries, in advanced countries. The WHO has produced a list of the ideal COVID vaccine, and that is to be very effective and safe in the long and short term, and safe to a variety of groups such as children, pregnant women, and the elderly, preferably to be single dose, give long-lasting protection, probably for several years. We don't know the current vaccine's duration of efficacy, easy to store, and that is really quite an important thing. Ideally, the vaccine is to prevent infection and not reduce disease severity and prevent transmission. The closest to the ideal vaccine we have is going to be Johnson & Johnson, which will be rolled out around April this year. This is a truly an important slide that has been come about recently. We used to say that COVID is the great leveler. This cannot be far from the truth. This slide shows that the amount of vaccine per person for a variety of countries. Every person will need only 2 vaccines. In Canada, for every person, the country purchased 9 vaccines. United States 7, United Kingdom nearly 6, Australia, European Union. On the other hand, look at Egypt and look to COVAX. This is the vaccine distributed throughout the world, if you like. And you can see that the number of vaccine per person is truly slim. And there have been really since this, really quite a lot of call of rich countries in the world to be content with the 2 vaccines sufficient to their citizens, and for these to be given to COVAX so that these will go to third world countries. It cannot be safe until everyone is safe, and the variety of waves that we have seen will tell us this. If there is nothing else to remember from this talk, please remember this graph, which is published in the New England Journal of Medicine on the Pfizer vaccine. This is a randomized controlled trial. These are people who took the vaccine, 22,000, and these are people who are put in placebo, which is 22,000. The fact that we have large number of population with COVID allowed also to have results fairly quickly. This is 4 months follow-up. And as you can see that the protection from COVID, this is a cumulative incidence, really happens about 12 days after giving the vaccine, whereby there is virtually very little people who have COVID. Whereas in the placebo, you can see that the difference of people who have been affected by all types of COVID. If we are to replot this graph on people who are dying from COVID, and this is now the Oxford vaccine, you can see that virtually people who have been given the COVID vaccine, the AstraZeneca, virtually there have been no deaths after that compared to the placebo bit. This is about the question, do we need 1 dose or 2 doses? And this is really a very interesting slide to look at. These are the neutralizing antibodies in the plasma. And this is used as a surrogate marker of efficacy of the vaccine. And what we need is around about 100 of these neutralizing antibodies to say that the vaccine is effective. This is the placebo, and as you can see, there is no difference in the neutralizing antibodies. And this is the vaccine itself. And at day 1, it is similar to placebo. Day 21, it increases a little bit. And this is when the second dose happened. And as you can see that the neutralizing antibody has jumped up quite a bit. Now, we don't know that if this second vaccine given in day 52, whether we will or won't have the same results. But this is the rationale behind giving 2 doses rather than 1 dose. In fact, there have been, this is from last week, New England Journal of Medicine, talking about whether delayed second dose of vaccine versus the standard regime, which has been recommended by the company, which people would prefer. And there is a clear ethical side to the vaccination in that if we have limited supply of the vaccine, delaying the second vaccine means that the majority of high-risk population will be vaccinated, but some people have to wait, and this is not the recommendation of the company. And these are the results. There are 2,000 people replied, and as you can see, it is really 50-50 for who wanted the delaying of the second dose and people who wanted to recommend the standard regime. And these are all doctors and readers to the New England Journal of Medicine. So it's really very similar to the really Brexit results. This is also an important slide which would explain the rationale of the way the vaccine has been rolled out to nursing home, then over the 80, then over the 60, then over the 50, then under the 50. It needs to give 20 people in a nursing home vaccination to prevent 1 death. For the over 80, you need to give 160. These are over 80 who are not resident in a nursing home. You need to give 160 vaccination to prevent 1 death. If you are over 50 and you are healthy, you need to give 8,000. However, if you are healthy and you are under 50, you need 47,000 injections to prevent 1 death. And there have been, in fact, plenty of questions whether this is necessary to give vaccination under this area. And the debate is going on. The second question, do you give vaccine to people who have had COVID confirmed? And there are no studies regarding this, but this is an indirect study from Imperial College looking to neutralizing antibodies in all health workers in the hospital who have been affected by the virus. And as I said, you need over perhaps 200, not 100, to say that you have protection from COVID. And as you can see, the first thing to say is that there is, in fact, huge variability in neutralizing antibodies for people who have been affected by the virus. And this is more on female than on male. And this variability has been a source of concern. And now the advice is for people who has the COVID being proven is to give 1 dose rather than 2 doses. And in fact, this has been given, and the observation is that the side effects of vaccine in those who have COVID are a little higher of myalgia and small fever. What about pregnant women? These are the recommendation of Pfizer and Moderna. It has not been tested in clinical trial. They have been ruled out, and they have been recommended to balance the benefit with the risks, if you like. But most pregnant women who work in hospital have taken the vaccine, and they will be reporting back of any personal or fetus problem. What about immunocompromised patients, which is really, I get plenty of questions regarding this. And then we recommend giving the vaccine, although it may be less effective. What about reaction of the vaccine? It is actually rare, and strong reaction tend to happen within few minutes after the injection. For this reason, when I took the vaccine, as will have everyone else, we have been kind of quarantined in a side room for 15 minutes. And if nothing happened, we are allowed home. The vaccine now through COVAX have been rolled throughout the world. And the aim of COVAX, which is the organization belong to the World Health Organization for vaccine, is to deliver 2 billion of vaccines throughout the world by 2021. And the first vaccination shipment will go out by June 2021. Can I say that the majority of the world, and certainly in the Middle East, the vaccine has already been shipped, and we are only February. You need to vaccinate nearly 60 to 70% of the population to ensure security. And this is probably behind Boris's announcement of July being in June, opening everything. My job has been over the last few months to promote the vaccine to the Middle East. However, the skeptics about vaccination are all throughout the world. And there are the 3 reasons why. The first, people believe that the vaccine is rushed. The 2 other things is safety concern, whether it can cause a neurological or Alzheimer or inflammation of the spinal cord. This is transverse myelitis, and there have been no evidence of that at all. Other safety concern is infertility. But there are other things which are as ridiculous as it can be, and that is the aim of the vaccine is to eliminate 1/3 of the population. And the other thing is that nanoparticles are in fact micro drones, which has been enable others to know us and to control us. And other people have an inclination to adapt outlandish claim because it is something for them to talk about and to appear throughout the crowds. The vaccine has major impact. It has eradicated the smallpox. It has eliminated the paralytic polio. It has done a great deal of service for measles, although there are something coming out. So this is my conclusion of slides. Corona has changed our personal and professional life and adversely affect the world economy. I have read saying that the biggest threat to man's dominance on Earth in the future and now is a little virus. It has divided the world between those who have and who have not. Variants are threats, but there are plenty of promising ways to combat these. Vaccines are definitely variable, effective, and available and safe. 2 doses are advisable. Acceptable distance, anything between 4 weeks to 16 weeks. We can only be safe when everyone else is safe. We have a long way to prevent corona, but the future is really, really bright. And this is my part, and you will see that the most interesting bit will be presented by Prof Goddard. Thank you.
So Nabil, thank you very much for that quite exciting presentation. I suggest that we all hold our fire on questions until both Nabil and Paul have spoken. We're going to move on to the second speaker for the evening, who is Prof Goddard. So Paul, if you can unmute and turn your camera on. and share. Nabil, can you stop sharing your slides? That will help.
Let me just see how I can do it. I lost my ability to have the full screen.
Okay, I've taken you. I've been presidential, and I've taken the power away from you. So we moved.
Would you like to stop? Would you like to stop sharing?
I've stopped you.
Good. Okay.
Yeah.
I start my video. Does it say?
Paul, are you there? You are.
I'm here.
So I'm going to. Yes, good man. I'm going to disappear off. So this is Paul Goddard, who's going to present to us repurposed drugs for COVID-19. Look forward to hearing this. And we'll have questions at the end. So if you have questions, you could put them into the chat so we can try to manipulate the timings. But there are only 17 or 18 of us on the screen, so it isn't quite the normal large group. But we will not want to tire our speakers out too much by asking them lots and lots of questions. So Paul, the floor is yours. Thank you very much.
Okay, thank you very much. First of all, I'm going to start off by saying this was really myself and Nabil together produced this work on repurposed drugs. And I want to thank also Maya Goddard, age 6, who drew some variants of the COVID for me. Now, at the start of the pandemic, the chief medical officer told doctors not to use drugs that hadn't been licensed for COVID-19 treatment. And my interest in these drugs, which the doctors have been told not to use, was stimulated by Nabil in a conversation when I phoned him up and checked that he was all right. And I was chatting to him and he said, yes, but we're being told not to use drugs that might actually be useful. Ferner and Aronson, in an article in the BMJ on the 8th of April last year, implied that COVID-19 was untreatable, which of course was absolutely correct if you weren't allowed to use any of the drugs. And they suggested that vaccines or drugs that targeted specific structures in the virus were more likely to succeed than old medicines repurposed. But unfortunately, creating vaccines takes a long time, and rolling them out has taken nearly a year, and that has been remarkably quick. And so far, no new drugs have appeared. A couple are on trial in Israel, but they're not ready for release. And in the meantime, over 2 million people have died. And of course, the doctors have been obliged to treat the patients, and so they've had to use repurposed drugs. Now, repurposed drugs are pharmaceuticals which have already previously been developed for use in human beings and are now being used for a different purpose. They've usually already passed safety trials, they're in use medically, and they're frequently outside the patent time, which is usually 20 years from the time of filing. And by the time they're actually in use, often there's only 5 or 10 years left of the patent. And the drugs are therefore cheap and not particularly profitable for the drug companies. Right.
We lost your microphone there for a moment, Paul. Are you?
You're fine now. Can you hear me now?
Yes, we can. Thank you very much.
They've usually passed safety trials and are in use medically, and they're frequently outside the patent time, usually 20 years from time of filing. Therefore, cheap and not particularly useful and profitable for the drug companies, although very useful, of course, for the patients. Now, Nabil said, was there anything we could do to try and change this? So we immediately put together a letter and replied to Ferner and Aronson. And I did this with the help of Nabil and Professor Gus Dalgleish, who is a medical professor of oncology and was previously a virologist, and he works in London. We supported the trials, but we pleaded for clinicians to be allowed to use their discretion in patients not entered on trials. And in the letter, we used hydroxychloroquine as an example because that was the example used by the guys Ferner and Orenson. We pointed out that remdesivir, which was used against Ebola, was reported already as being useful in the late stages of COVID. And at the stage when oxygen was needed, the interleukin-6 antibodies used for rheumatoid arthritis we suggested might be helpful. And that includes tocilizumab, which, if you remember, the Prime Minister was trying to pronounce about a week ago. And it's tocilizumab. MAB there stands for monoclonal antibodies. So if you see a drug that's got MAB at the end, that's a biological drug, a monoclonal antibody. We concluded that a doctor's duty is not to cause harm, either by intervention or by inaction. And not giving the drugs, of course, would cause harm by inaction. We didn't see any conflict between enrolling patients in clinical trials and trying off-label HCQ, AZM, antiviral drugs, anti-inflammatory agents we mentioned in the letter in COVID patients, and of course, oxygen. So here's a list of the things we were referring to. HCQ, AZM, antiviral drugs, anti-inflammatory agents, that's steroids, non-steroidal anti-inflammatories, monoclonal antibodies, oxygen, and separately, we advocated the use of vitamin D3 and masks. And we did this on Facebook, YouTube, and in the book Pandemic. Since the BMJ letter in April, a plethora of drugs have been put forward for use in COVID-19, and it takes many years to develop drugs. So these repurposed drugs are already available and very important. And here are the drug groups which are possibly of value. Antivirals, antibiotics, antimalarials, anti-inflammatory drugs, either corticosteroids or non-steroidal, anti-testosterone, anticoagulants, antiparasitics, that's ivermectin in particular, neurologically active drugs like amantadine, oxygen, plasma, antihistamines, vitamin D3, and a few other vitamins, vitamin C, zinc, and such like. So what have the trials shown? They've shown there is no benefit from hydroxychloroquine in the late stages. They're still not sure about in the early stages, but certainly not in the late stages. But one of the things and one of the reasons they were saying you mustn't use it was because they said that it was dangerous. But there are many, many people, up to 1 million or so people taking hydroxychloroquine in Britain alone for arthritis. And looking at those, there is no association with COVID-19 mortality and hydroxychloroquine. So it does not look as if it is dangerous, but not particularly useful, but not dangerous if medically prescribed and monitored. So let's look at this. We'll give it a cross, no. And so if you look here, here's these COVIDs, they're the winners in this particular one. What about AZM? A macrolide antibiotic, it's useful in chronic obstructive airways disease, but the principal trial found no benefit in early COVID. The recovery trial found no benefit in severe hospitalized cases. And so we'll give that a cross. That's no good either. That's not to say it's not useful in people for other things, but it is not specifically useful in COVID. What about the antiviral drugs? Yes, the remdesivir, particularly in combination with baricitinib, which is an anti-inflammatory JAK inhibitor, that's janus kinase inhibitor. Now, that's inhibiting the cytokine storm. It's one of the things which the JAK, they actually set off, they're part of the cascade that sets off the cytokine storm. And the inhibitor there is very useful, that the patients recovered faster when they're on the antivirals and on the anti-inflammatory there. Also, you can see here, tocilizumab has come out as being successful. And favipiravir, that also has been approved. Acyclovir has been put forward as being useful. It's been studied it's been studied in the laboratory, but it's not yet been studied clinically. And it does have effects against COVID when it's in the laboratory. So antivirals, we give it a tick. And here the doctors are winning here. What about the anti-inflammatories? This is the one that the Oxford people came out with a great big story about and said, look, it's wonderful. We've saved a lot of lives. And it reduced deaths in hospitalized patients with severe respiratory complications. In September 2020, the World Health Organization came out and said the same thing for hydrocortisone. So it doesn't have to be dexamethasone. Hydrocortisone does the same sort of thing. Well, this isn't surprising because it was in the medical textbooks when I was a medical student. In high-dose corticosteroids are maybe of value in end-stage pneumonia. And Professor Landry, the lead of the recovery trial, said, had we been prescribing this drug from February 2020, we would have saved 4,000 lives. Interestingly, in some countries, they were prescribing it from February 2020. What about the anti-inflammatory drugs, the non-steroidals? Well, aspirin, colchicine, and tocilizumab are particularly useful. Colchicine is an anti-inflammatory which is used for people who have gout, and a randomized double-blinded placebo trial reduced the length of oxygen therapy and hospitalization. So that's useful, and so is tocilizumab. That's according to the big recovery trial. So we'll give the anti-inflammatory agents 3 ticks. They are particularly useful in the moderate or later stages, and that is the time they need to be given. What about oxygen? What about oxygen? Well, this is a picture of the Alps penned by myself in a hurry, and there's a skier, and the skier is being chased by the COVIDs there. And as we know, a lot of people who were skiing went down with very bad symptoms from COVID infection. So why was this? Why were the Alps particularly affected? Why were the ski resorts so bad? This led me to speculate on this. And I spoke to Nabil early on about this and pointed out that I thought oxygenation here was a vital thing. Pneumonia in the upper zones typically likes good ventilation and relatively high oxygen availability, whereas pneumonia, which is in the lower zones, typically likes low oxygen. Now, tuberculosis sufferers, people who are suffering from tuberculosis, they used to be sent to the Alps. Why? Because they improved, they got better, they recuperated in the Alps. Why was this? This is because a lack of oxygen. But COVID-19 flourished in the Alps, so it was doing well with low oxygen. And it mostly causes pneumonia in the lower zones. No. Using non-invasive aids to ventilation has reduced the number of patients going on ventilators.
I think the microphone's just there. That's what's happening. You're just tapping.
I touched the microphone. At the stage when oxygen is needed, high doses of corticosteroids are helpful. So what we're saying here is that oxygen is very useful, but you don't want to keep people on ventilators if you can possibly help it. Now, the NHS is giving out pulse oximeters because COVID-19 causes silent anoxia. People develop anoxia without being aware of it. Their oxygen levels go right down. Now, normally speaking, if your oxygen level goes down, you become totally aware of it and you try to breathe faster and all that sort of business. But with COVID, they develop silent anoxia. This may be due to a central effect on the central nervous system, or it might be some other thing, but certainly happens. Now, breathing exercises are something which we have advertised and spoken about over a period of time during the COVID pandemic. And they're particularly helpful in the prone position. And this is something physiotherapists can help with. So oxygen, yes, definitely very useful. In addition to the drugs that I've talked about earlier, there are quite a number of other repurposed drugs that are coming to the fore. Antihistamines, for example, a big study of 250,000 Californian patients' medical records showed that those patients who were on antihistamines did not suffer so badly from COVID. That doesn't mean to say that they're necessarily going to be, antihistamines are going to be useful. It does mean, though, that if you are on antihistamines, this is helpful for you. Ivermectin is approved for parasitic infections, so it's another drug which is potentially useful for repurposing with COVID. And early treatment with ivermectin has decreased viral load, and it's caused a subjective decrease in anosmia. And it is one of the things put forward by people who've produced prophylaxis protocols and early outpatient protocols. And here is the Frontline COVID-19 Critical Care Alliance. They are particularly keen on ivermectin. Up until the middle of January, the National Institutes of Health in America were banning its use. But in January, they looked at the evidence and they decided to be neutral on it, in which case they said, you can use it, but we don't know whether it is useful. But there is a lot of clinical support for it. Now, baldness. I know quite a lot about baldness, and baldness is linked to a greater risk of severe coronavirus symptoms. That came out in the newspaper sometime in the spring or summer, and it did amuse me. So I created some cartoons about that. You're not shaving your head anymore. Why is that? Well, they found out that bald men were at greater risk from the virus, so I'm letting it grow. Well, what are you doing now? I'm selling wigs for bald men. Are they real human hair? They're not even hair, but the virus doesn't know that. Well, is there any truth in this? There probably is, because in some studies originally, twice as many men were dying from COVID compared with women. And here's an interesting thing, that patients with prostate cancer and on androgen deprivation treatment have a lower risk of serious complications from COVID-19. A trial of anti-androgens is underway, but it's not something which I personally want to take part in. Now, the best treatment is prevention. We've been told that already by Nabil, and vitamin D3. Low vitamin D, in other words, vitamin D deficiency, is a major risk factor. This has been shown in lots of studies, and one study from Barcelona has even suggested that early vitamin D3 administration cut deaths in patients who've been hospitalized because of COVID. I'm not saying that it's necessarily useful for the hospital patients. I don't know whether their study there is very robust, but what I do say is it's very vital that people in Britain should be on vitamin D3. Why? And that is because we do not get enough sunshine, and for at least 6 months of the year, we do not produce enough vitamin D, and we're running along with a level of vitamin D deficiency. Vitamin D, we used to think, was only important for the prevention of rickets and osteomalacia, but it turns out, in fact, that's not the case. It is basically a hormone, and it is very important in the immune system. It also actually helps control the cytokine storm. So it actually controls the immune system in a variety of ways. Diabetes and obesity, both are comorbidity risk factors. And so it's very important to carefully treat diabetes, to encourage exercise, and to encourage weight control. So the best treatment is prevention. And gain of function studies, I think the reason that people were interested in doing gain of function studies was really for prevention. Virologists worldwide have been doing studies in which they take a harmless virus and they alter it so it can infect human beings. The raison d'etre being, then you know what type of disease might be out there sometime coming towards us. This is rather like the astronomers looking up into outer space and looking at comets and saying they may be coming towards Earth. The only difference is that what they were actually doing was the equivalent of making the comets come towards Earth. So rather than gain of function, this should be called make another disease studies, mad studies by mad scientists, and it should be banned, as it previously was, to prevent more modified viruses from being released. So best treatment prevention, there's to prove that I was willing to go along and have my vaccination. I had the vaccination. 24 hours, I didn't have any symptoms from that. Then I had a couple of days of slightly achy legs, nothing tremendously bad. So had the vaccination, very pleased to have had it. I had the Oxford. Other things such as keeping within your bubble. Here's the chap. He's dreaming away about a bubble, but his wife's not inside it. So finally, what drug groups are there then? Here's the antivirals, moderately useful. Antibiotics, azithromycin and then the antimalarials, hydroxychloroquine, no specific benefits. Anti-inflammatories, very useful. Non-steroidals are also useful, proven by large trials. Anti-testosterone, well, that's preventative. We don't know whether it can be useful when you've got it. Anticoagulants, they're useful in the late stages with intravascular thrombosis. Ivermectin, strong clinical support. Amantadine, clinical support in patients with CNS impairment because it stimulates the brain, and so that must be helpful if people have brain fogging. So finally, here's my book and any questions.
Thank you, Paul. That was very stimulating. And a quick run around all the drugs. So if I could ask Nabil to come back in. Paul, can you stop sharing the screen? Thank you very much.
No trouble.
So I'm expecting a few questions. And so if people, no, that's not what I want.
So it says here, I can't start my video because the host's stopping me from doing it.
Well, you don't, maybe I did that. So Monica has just asked a question. So Monica, you can, if you unmute yourself, Monica, and okay, Nabil, good to see you.
Hi.
So Monica, you've got a question for Paul.
Yeah, no, I mean, so interesting. Lockdown, is there any relationship between lockdown and the mutant strains? There's a feeling that all viruses mutate. Remember, Paul, I have read your book. I thought it was brilliant. All viruses mutate. They want to survive, but they generally become more transmissible, but less virulent. This one has done something different. Has lockdown caused it?
Right, that's a very interesting question. The Kent variant has been looked at by the Norwegian virologist who pointed out that this COVID-19 came from the laboratory in Wuhan, and he says this has also been altered. In other words, somebody or something has taken this and altered it, added spikes, and he does not believe this is purely due to mutation, due to evolution.
Okay.
So conspiracy theory then?
No, cock-up theory.
Oh, that one works better usually.
Yeah, I think cock-ups occur frequently. Conspiracies usually are there to hide a cock-up.
All right. Maha, you had a question for Paul about COVID and where pneumonia occurs. Do you want to ask it, or will I? If you can ask it, go ahead.
Hi, everyone. Yes, Paul, I was just interesting about the radiological changes you mentioned, that you thought that COVID was mostly lower lobe pneumonia. I'm just remembering all the x-rays I've seen in recent times, or right from the start of the pandemic. It sort of changes, radiological changes seem to be spread throughout, really, not just lower. If anything, sort of start around the middle and then sort of spreads back upwards and downwards. And does it really sort of, well, I suppose it matters. I'm going to say, does it really matter at all? It probably does matter. Of course, the more lung tissue is involved, the less likely the patient gonna do well.
Well, one of the reasons that you see pneumonia more in the mid and lower zones is simply because there is more lung there.
Yes.
So
yes.
I've been following what the radiologists have been saying, and it does seem to me that it is mostly, it is predominantly mid and lower zones, and it's not an apical. It's not an apical change. The things like tuberculosis, coccidioidomycosis, and a number of other histoplasmosis, these tend to go to the upper zones. Upper zone diseases are very specific.
Yeah, I wasn't claiming that it's upper zone. I was just thinking that it's more of a widespread rather than. Anyway, I take your point. Okay, thanks, Paul. Thank you.
Thank you, Maha. Can I just remind you that Nabil's talk is also open for discussion. If people want to ask any questions. Jonathan, you had a question, I think, for Paul. So if you just unmute yourself and
unmute,
come on screen.
Okay. Apparently I can't start video, but anyway, I can talk. Can you hear me?
Fine. Yes, we can hear you fine.
I can start now. Okay.
Oh, there you are.
Okay. Hi. Yeah, so I was concerned about the issue of long COVID and whether we know enough about why you develop it after the acute illness, and whether there are predictors in terms of the sort of progress of the acute illness that tell you that patients are likely to go into long COVID afterwards. And also with these various there's one for Paul, if any of these drug interventions seem to have any effect on whether people progress to long COVID symptoms or not.
I can answer that if you want. Currently, the more severe the disease, the more likely that post-COVID symptoms will occur. Having said that, 30% of people who have severe symptoms of post-COVID have very, very mild disease or even asymptomatic disease. There is now a study called Phosphor-COVID, which really recruiting 10,000 patients, in which variety of things has been done. The initial part of the study, the first part of the report of the study, showing that the main cause for post-COVID is small vessel endothelialitis. So it's actually small vessel inflammation, like vasculitis, like small cell vasculitis, which is sub-radiological and sub-biochemical. However, actually, we have to remind ourselves of chronic fatigue syndrome, which has run for a long period of time, and many clinicians did doubt it. Those people who are in the MidCai for some time, I have invited when I was a president, Simon Wesley, who is the psychologist who doubted the chronic fatigue syndrome, and he eventually has been harassed and threatened by the chronic fatigue patient and has to go to Iraq. And he said it was more safe for him to look after the troop in Iraq than to stay in the United Kingdom. But it is actually very, very similar to chronic fatigue syndrome, but magnified. And I have seen dramatic cases. If the society allows me, I'm happy to talk about post-COVID at some point. It is important, it is with us, and it will stay with us for a long period of time.
I would have thought that tocilizumab would have been useful in them. What are people saying?
It is. I mean, tocilizumab has just been approved to be a post-COVID, a severe COVID treatment, and but only has been introduced several weeks ago, Paul. It hasn't been there for a long period of time, at least for COVID patients.
No, it's been in the trials though, hasn't it?
Yeah.
But can I just follow up on that? So were there any markers of, because you mentioned that many of the people with long COVID only had mild initial disease amongst, so in those patients, were there any other markers, either biochemical or other tests that showed that they were at a higher risk? Did they have a higher level of circulating antibodies or
None.
higher?
None. Almost none. I mean, the patients I had, I do CT scans, lung function tests, battery of blood tests, echocardiogram, and I would say 9.5 out of 10, all these investigations come as normal.
And the last thing is it different from other viruses? Because we know that many viruses produce a fatigue syndrome following a virus illness, sometimes just for a few days, sometimes for months afterwards. And is the COVID run really any different than that, or is it just really a non-specific viral phenomenon?
It is nastier than any other virus. I mean, I would say just the effect is so magnified. And perhaps the main reason for this, that unlike other viruses, the effect on the brain, the heart, and particularly on the blood vessel seem to be rather unique for COVID compared to the normal flu. Incidentally, there have been 0 flu reported this year and last year. We don't know why.
Thank you.
So, Monica, if you want to come back in, just to say that in the February BMJ, if you're a BMA member and you get the BMJ, there was that Doctor Supplement magazine had a 3-page article about long COVID and chronic fatigue syndrome, which is very interesting and well worth reading. So, Monica, you've got a long question for Nabil, so I'll let you read it out.
Yeah, Nabil, obviously I see the other side of your telephone outpatient appointments now. In terms of feedback, I think it's great that patients don't have to travel, particularly those who are really frail. It's very easy for them to have their representatives alongside them, which seems to make a big difference. In terms of feedback, patients don't feel that they've had a real outpatient appointment because unless they've seen somebody and been examined, it's not real. And the other thing is that the impact on us in primary care is massive. It's absolutely huge. We're on our knees. So just as hospitals are emptying, we've got winter pressures, we're vaccinating, and outpatient generated work is huge. I know it's being flagged up through official channels, but it is huge.
I entirely agree, Monica. And whilst, I mean, most of my clinic currently are hybrid clinic. For a new patient, it is face-to-face. For those patients, for example, a patient who just, we have run investigations and they need the results of the investigations, these are good for a follow-up. To be honest, on me personally, on my family and my set of colleagues, as I mentioned, the phone consultation has been successful enough to do the international phone consultation clinic, which I've been doing now for a period of time. Will things go back to what they were before? I honestly don't think so, Monica.
I think this is now here to stay.
Indeed.
And we're just going to have to work together to work it through. But yeah, I agree with you. I can't see how it'll ever go back. But thank you.
Tom Fruin, you've got a question, I think. If you want to unmute and show your video.
Yes, yeah. Wait a minute, hang on.
I was asking, will you ever get true herd immunity if children are not vaccinated?
That is truly an important question. And this is the main reason why the vaccination have been undertaken the below 50 years of age, is not to stop death from happening, is just to make sure that the 60–70% of population are vaccinated to ensure that there is a herd community. So the answer to that is no, we will never achieve it without vaccinating 70% of population in all ages.
So why are they not doing children as well?
I think, I'm not sure actually, and if they're not doing children, then they are perhaps ill-advised by doing so. They do need to do children.
Well, the alternative, of course, is will they catch it? And if they've caught it, how long will their immunity last? Because children, once they're over a year old, from then on, when they catch diseases, they tend to get good immunity, which lasts for quite a long time. So maybe they should be allowed to catch it once everybody else has been vaccinated.
Mm. So Nabil, do you or Paul know if there's any studies going on looking at children at the moment? Because there's still lots of ongoing work happening.
Oh, there are plenty of studies are going to the children who are affected, and about the antibody levels of the state of immunity. What I didn't know is what Tom has said, that there is now a policy that you don't vaccinate children. This is new to me. There are plenty of studies looking at this, the COVID children or the Kawasaki disease, similar manifestations. But there are plenty on neutralizing antibodies over a period of time after providing vaccine to the children. Because people say that children can't mount enough immunity for COVID. This is why we don't see it in COVID, at least a severe bit, because the severe bit is happened because of exuberant autoimmune response, which the children can't mount.
So Lois, you had a question?
Yes, I just wondered if there have been studies being done to measure vitamin D levels in long COVID sufferers and chronic fatigue syndrome sufferers.
Yeah, the phosphor study, the phosphor COVID study, which, as I said, will be 10,000 people, are measuring battery of investigation, including zinc and calcium and vitamin D, CRP, all infection markers, and all levels, as well as radiological methods. It's a very comprehensive study supported by the tune of 60 million by the government. So it is really, and we'll report apparently the spring of next year.
Okay. Monica just points out in the chat, if you haven't seen it, that in practice, what's happening is that people as low as 16 are being vaccinated if they have other illnesses at the moment, but mostly. So I was at a vaccine clinic this afternoon, and the patients we were seeing were all people whose dates of birth were in the 1950s, so people in their 60s to 70s mostly.
And Maha has pointed out that the reason that vaccine hasn't been rolled out to the children is because the clinical trial didn't include them.
Yeah, and that'll take some time. Okay, that's quite a lot of comments and questions. So it looks like we've come to the end of the questions, but I'm just going to give people a moment or two to say one last thing. And like the auctioneers would say, going.
Okay, one last thing. One last thing.
One last thing.
Just the question of back to chronic to long COVID is, I think Monica pointed out that the people with long COVID may have a bit of a premorbid personality that's in common with people with viral fatigue syndromes. And it seems to me that the patients I've seen with the long-standing fatigue syndromes, which often turn up at cardiology clinics in case they've got heart failure, etc., there's a strong psychological element in it, and this is what differs between a brief post-viral fatigue syndrome and a long post-viral fatigue syndrome. And it may be that the long COVID may consist of an early phase, which is due to inflammatory processes, and a late phase, which is due to psychological response to that, and that these may need to be distinguished if you're doing some kind of research on treatment for it, because people who remain fatigued years later seem to have a definite kind of personality characteristics.
Currently, the NICE guidelines have produced a blueprint of managing long COVID, and it is very similar to pulmonary rehabilitation program used in COPD, but with the essential component is a psychologist's input in it, which is not necessary in the pulmonary rehabilitation program for COPD, or not a mandatory, but this is really the added one. There are people who, as I said, that will be now rolled out and funded by the government. Some of the patients I have seen, they have truly debilitating disease, and extreme fatigue is the major component associated with significant low mood, verging on severe psychotic depression. It's a really quite a real thing.
Yeah, I was people who had a slight doubt about fatigue syndromes until I got it myself once, and it became very convincing at that point that it really was real.
It's real.
But on the other hand, fighting it off definitely seemed to help by just ignoring it and getting on doing what I was going to do anyway. And I got better in about 10 days. But some of the symptoms were still there 3 months later.
So it's been a very active and enlightening discussion. So I'm really good. Lots of people have put in the chat about thank you to Paul and Nabil. I think you've done us a real service by pulling together some of the facts and the figures, some of the information about the drugs. Paul, that's been very helpful. And I think you've really served to educate us all well tonight. I think we can go away a lot more informed about what's going on. Hopefully, between Peter Carpenter and myself, tonight's talk will go onto the MedChi website within the next week. And people who weren't able to make it or who need to go back and look at it again, because there was a wealth of information, a wealth of facts being poured out on us, which is really good. So I'm very grateful to you both for joining us and for talking to us. And thank you to everybody who's joined in. And I hope you're all keep safe. I don't need to say drive home carefully, because you will. And I look forward to meeting with you all again on the 10th of March. So David Mumford, who's our speaker on the 10th of March, is in the audience tonight, as it were. And so we're going to hear about David talking about cross-cultural psychiatry and education. David did a lot of his research in cross-cultural psychiatry and cross-cultural illness. So I hope it'll be quite fun. So he's doing the Long Fox lecture on that evening. So I'd like to invite you all back for that, and you will get detail. I think actually Sam has already sent out details by email to ask people if they want to join us. I'm looking forward to that. So thank you very much to everybody for your participation and your contributions and active discussion, and have a good evening and keep well and keep safe. And goodbye, everybody.
Good night.
Bye.